Okay, sorry. So good now.
There we go.
I got it.
Okay. This is where it gets good anyways. SVT. 3 different pathologies that we know of can cause SVT. So we can divide that into AVRT, AVNRT, and atrial tach.
So what does SVT stand for?
Super ventricular tachycardia.
Mm-hmm.
So
Super fast ventricular is the ventricles, and tachycardia is fast.
So this is kind of doctor speak of what's going on. Hell, I don't know. I just know it's above the ventricles, right?
Okay.
So there's 3 different pathologies that can cause that. AVRT is atrioventricular reentrant tachycardia. So this is typically created like if you have, here's your SA node, here's your AV node. You have your internodal pathways here, and then you have your interatrial fibers that extend out, right? And then your bundle of His, your left and right bundle branches, and those come out and then become the Purkinje fibers, right?
Yep.
Okay.
Pacemaker cells.
Right. So typically with AV reentrant tachycardia, you have an accessory pathway. So we see this with like Wolff-Parkinson's Y, right? And this is known as like a bundle of Kent. Okay.
Hey, will you explain an EKG finding that would rule out Wolff-Parkinson White?
Rule out Wolff-Parkinson's Y?
Yeah.
So like,
If you are suspicious of it,
so if you had no delta waves,
no delta waves.
right, and you
'Cause then,
had
yeah, you have to
a
have-
normal P-to-R interval, I would say you
Right.
definitely don't have.
Okay.
Yeah. So, so Wolff-Parkinson's White, what is that? So
Looks
the
like a
energy
little
starts
bow
here.
tie.
Right, energy starts here and it starts to pre-excite the ventricle, right? So remember that the AV node delays the impulse, right, before it comes to the rest of the ventricle. Well, there's no delay here. So if we were to look at a Wolff-Parkinson's White waveform, you'd have a P wave, and then right after the P wave, you'd start sloping up because we're pre-exciting the ventricle over here.
Oh.
Then the rest of this is going to eventually catch up through the normal pathway, and you'll get your normal QRS look like that. But what you have is this sloping up into the normal QRS. We call that a delta wave, okay?
Oh, okay. So if it slopes into the QRS,
That's a
it's
delta wave. Right, and that's an indication of Wolff-Parkinson's White. Now, if one of these people, let's say they're born with Wolff-Parkinson's White, they have this little accessory pathway, they have no reason to get an EKG, they have no idea that they have it, right?
Okay.
Then one day, they become teenagers and they start drinking energy drinks. And you have this sympathomimetic that starts to irritate the ventricle or whatever.
Okay.
And they have a spot out here in the ventricle where PVC is originated, right?
Okay.
So they have a PVC. That energy can flow retrograde through here, back down, and repolarize itself over and over again.
I see.
Right.
So it's,
And it creates this loop of energy. Okay, that's where that reentrant.
so instead of, I'm saying it for the camera, instead of talking about like the blood flow, this is like the energy, the pacemaker cells
Right.
that are going in
In a circle.
abnormal of how it should be going.
Right. So this is a reentrant, a loop of energy between the atria and the ventricle. So an atrioventricular reentrant tachycardia.
Cool.
And when that happens, the QRS narrows, and you get something that looks like this, right?
Oh, okay.
And so the question then is, well, what the hell's going on? Because I can see my QRS, but I can't see enough junk in the middle to really know what's going
Yeah.
on. That fits that definition of SVT, right?
Okay.
So now, another pathology that can cause SVT is AV nodal reentrant tachycardia. So if we blow up and look at just the AV node up close, okay, AV node comes down and extends into the bundle of His here, right? If you look at the fibers in the AV node, if we zoom in even closer, you'll see that the fibers kind of branch out like so. And this is how we propagate energy as we move about, right? So we get energy moving, and there's little cross bridges between these. So one impulse can then spread out and more disseminate out,
Makes
right?
sense, yes.
But let's say right here we have a little bit of injury. Maybe
So
maybe
you
some
can't-
stretch forces or something is applied. So the energy, rather than flowing through here at the same time and kind of crossing each other out here, the energy goes slower through here. So now it comes through here and it zips back up in this direction and it starts to repolarize itself.
What is that called again?
That's re-entry, right?
Re-entry.
Re-entry. That's a re-entry phenomenon. So this is AV nodal re-entrant tachycardia.
Oh, okay.
Okay. So again, what happens is you have an impulse within the AV node itself that is firing back on itself over and over again, and that causes this. You know, very similar pattern. You have a very fast QRS with a bunch of junk in the middle that we don't know what's going on, right?
Yeah.
Okay. Third form of SVT is atrial tachycardia. You have one site in the atria that's just really kind of pissed off, right? And it's just firing over and over again very, very fast, okay? And again, what does that create? It creates this.
The big, very, well, it's regular, but
Normal,
very fast, tacky.
Normal QRS tachycardia with a bunch of junk in the middle that we don't know. Is that a P wave? Is that a is that a T wave? What is it? Who knows, right? So those are the three potential pathologies that creates SVT. Either reentry between the atria and the ventricle, reentry within the AV node itself, okay, or a single site of ectopy within the atria that's very irritated and firing very rapidly. So treatments then. First line treatment is vagal maneuvers. So remember that vagus nerve you were just talking about, right? We're trying to stimulate that.
Okay.
Stimulating the vagal nerve. How do we do that? So a couple different methods, but the one I found most successful is I will have my patient sit down, I push on their abdomen really, really hard, and I have them try to resist with their abdominal muscles.
Okay.
And as you do that, you're increasing the intra-abdominal pressure, that stimulates the vagal nerve. You get vagal nerve stimulation, which is a parasympathetic nerve. So you're getting a flooding of the cardiac tissue with parasympathetic tone, and it slows everything down, right? And sometimes, if you do this right, you know, about 30% of people can be taken out of SVT just by doing vagal maneuvers.
Nice.
Right. Second line treatment is a drug called adenosine.
Oh yeah. Okay. That's a very common word. You'll learn it a lot in.
Right, so if you go back to anatomy and
ATP.
physiology, adenosine is ATP, right? Adenosine triphosphate. It's the chemical energy of the cells.
Yep.
So essentially what we're doing is we're flooding all of the cardiac tissue with chemical energy. Well, when you give energy to a cardiac cell, it starts to turn on its sodium-potassium exchange pumps, right?
I know all about those.
Right, so it's kicking sodium out, it's pushing potassium in, and as long as it continues to do that, we can't have a depolarization. So you basically have stopped the heart, right? You stop the heart with chemical energy, right? And then the hope is that once it starts back up on its own, the SA node takes over as the dominant pacemaker, right? And everything goes back to normal.
Wow.
The third method here is actual electrical stopping of the heart, right? And so we can do this with cardioversion. And
Which basically is still the same concept.
yeah, same thing. It's just we're not using chemicals. Now we're using electricity, and we zap the patient, and we stop all electrical energy. And again, the hope is that the SA node takes over, and it follows through the normal pathways. It doesn't follow through these reentrant feedback loops. Right. So that's SVT. Okay.